everyone. Thank you for this invitation to talk about a topic that's very important to me. Great. So, as I was saying, this is obviously a very important topic that's not important just to me, but to other urologists as well. It's probably one of the most common things as a urologist that we see in our office. So, there's a lot of misconceptions about urinary tract infections, so I'll try to kind of clear up some of those, and then I'm happy to keep this interactive. If people have questions, feel free to ask along the way. I will also like to apologize before I start. I initially thought that this talk was for, first of all, how many physicians do we have in the room? Do we have any retired physicians or working? Oh, no. So I was told initially that the talk was for physicians. So there was a bit of a miscommunication. So some of the slides are maybe a little bit too in-depth. So I did change some of them, I'll be skipping through some of the slides. But if there's too much medical jargon, just feel free to raise your hand. Let me know. I'll clarify stuff for you. But I'll try to keep this very user-friendly here. So as was mentioned, I'm with UC Irvine. We actually have opened up a new office not too far from here in Yorba Linda. The address is up there. We just opened up about a year ago now, and things seem to be going very well. And if any of you have any urology, it's multi-specialty clinic. So we have cardiology, dermatology, urology, as well as other specialties. So if either yourselves or family members have any medical issues, we'd obviously be very happy to see you there. All right, so first of all, I don't have any disclosures. Just a little outline of what I would like to cover today. We go over some definitions. I think this is very important because people throw the term out as urinary tract infection, and a lot of times, you may have the symptoms of a UTI, and UTI is short for urinary tract infection. That's not always the case. So we'll talk, I will spend a lot of time on the definitions because I think that's very important. We'll talk about how common it is, the incidence and prevalence, so how common it is out in the population. What are the risk factors that are common for developing urinary tract infections? I'll explain what ASB is. It's short for Asymptomatic Bacteriuria, and I'll explain that on one of the following slides. And then specifically the talk today was also about urinary tract infections in the elderly population. So we'll spend some time on that, how to prevent urinary tract infections, and then we'll wrap things up. And again, the main issue here is to distinguish between urinary tract infections and that ASB, which is asymptomatic bacteria, which I'll define for you, and kind of what the role of antibiotics is, because that's how we usually treat urinary tract infections. We'll talk about why antibiotics are good, and sometimes they can be bad for you as well. So we'll cover that, and then we'll talk about some of the challenges that are, especially in the elderly population, of having urinary tract infections. There can be some challenges in the diagnosis and also the management of urinary tract infections in that population. So first of all, again, I think definition, we should kind of be all on the same page as to what a urinary tract infection is. Simply put, it's just an infection that's most often it's caused by bacteria. You can get viral infections, you can get fungal infections in the urinary tract, but I'd say about 95% of the time it's a bacteria. And that's what antibiotics work for treating bacterial infections. For viral infections, you need antivirals. For fungal infections, you use antifungals. So 95% of urinary tract infections are caused by bacteria. And it can occur anywhere along the urinary tract. So when we talk about the urinary tract, we're talking about it can be kidney, it can be bladder, it can be prostate, obviously in men. So usually when we talk about urinary tract infections, when doctors will talk about an upper urinary tract infection or lower urinary tract infection, you probably hear lung doctors talking about upper respiratory tract infection or lower respiratory tract infection, very similar. So when we talk about upper urinary tract infection, we're talking about infections in the kidney, because that's the upper urinary tract. And when we talk about lower urinary tract infections, we talk about infections primarily involving the bladder. So what are the symptoms of a urinary tract infection? For those of you who have had urinary tract infection, I probably don't even need to list these out. You probably already know. But typically the symptoms are frequency of urination, having a strong urge to urinate and sometimes not even being able to hold the urine. Burning is a very common symptom that patients complain about when they have a urinary tract infection, or pelvic pain. Sometimes the urine can be cloudy, dark. You can have blood in the urine. It can smell foul. Abdominal pelvic pain is a very common symptom as well. If the infection, those are typically infections of the bladder. Now, when the infection, if it's not treated or goes unrecognized, it can spread from the bladder to the kidney, and that's when you can get more serious symptoms like fever, chills, pain in the back where the kidney is located. That's when you start developing like an upper urinary tract infection. And then when you have fever, the concern too is, can the infection now leave the urinary tract and can it enter your bloodstream? And when that happens, you can develop what's called sepsis, which is like life-threatening condition where, usually you're admitted to hospital and need the IV antibiotics. So sometimes people present with, like men, we'll talk about the incidence, but it's definitely more common for women to get urinary tract infections, but men can get them as well periodically. And sometimes they can present with a rectal pain, maybe related to infection of the prostate. So what causes urinary tract infections? Like I said, most of the time, 95% of the time, it's bacteria. The most common bacteria that causes it is E. coli. E. coli is present in the colon, in the rectum. It's a very common bacteria. That's probably like 80 to 85% of urinary tract infections are caused by that bacteria. Other infections, other bacteria that cause UTIs commonly are things you may have heard of: Enterococcus, Proteus, Pseudomonas. Those are probably the other common ones that we see. The risk factors for it, usually in younger people, it can be associated with sexual activity. So I see typically it's women in their 20s and 30s. It's a lot of times they notice that they get infections following sexual activity. Like I said, it's definitely more common in women, and the thought there is, could it be because of the anatomy? Women's anatomy, the urethra is very short. It's close to the vagina, which is close to the rectum. So you've got 3 different openings in a very small area, and we know that there's a lot of bacteria in the rectum. And we all have bacteria on our skin, in our mouth, in the pelvic area. So because the urethra is so short, it's very easy for the bacteria in that region, in the pelvic area, for it to enter the urethra and make its way into the bladder. Men have a longer urethra, so it's a longer tract for the bacteria to travel. So therefore, it's less common to see infections in men. People who use catheters. So a lot of times some people can have difficulty urinating, and they have to use a catheter, which is a tube, to help empty their bladder. So whenever you put like a foreign body, obviously no matter how clean you think you're being, there's always going to be some bacteria that increases the chance of you introducing bacteria into the bladder if you have to use that to empty your bladder. Some people live with the catheter. They, for some reason, if they don't have the manual dexterity to put the catheter in to drain their bladder, they sometimes have to live with the catheter permanently, and bacteria can colonize the catheter, and that can be the source for the infection. In children, especially in boys less than 1 year of age, being uncircumcised can be a risk factor. But usually after the age of 1, with proper hygiene, it's less common. So, with proper hygiene, nowadays we're seeing that this is less of an issue, being uncircumcised. We do see that there seems to be a family predisposition for bladder infection. So a lot of times I see women who have a lot of urinary tract infections, and we ask about other family members. A lot of times they say, oh, my sister has them, my mother has them. So there could be a predisposition to infections if you have a family member that has had issues. And we don't really understand the reason for that. Is we just, when you look at the studies, it seems that there does seem to be a relationship with a family history of having infections. We definitely know diabetes is a risk factor. Again, diabetes puts you at risk for many things, and one of them is urinary tract infections. And the thought there is probably because of diabetes, usually you have high sugar, you have sugar that ends up leaking through the kidneys and into the urinary tract. And that can cause some of the same symptoms of a urinary tract infection. The frequency of urination is a very common symptom. And it's thought that the sugar it's like fuel for the bacteria. They like sugar, and that can cause them to multiply. And it's very common that patients with poorly controlled diabetes can get recurrent urinary tract infections. And we keep giving them antibiotics, but we're not solving the underlying problem, which is keeping their diabetes under better control. Because if you were to do that, a lot of times the infections become less frequent. So this is just a diagram again, just pointing out, sorry, I don't know, you probably can't see it too much in the back, but just to show you like a diagram representation of the bladder. Here's the urethra, and here's the uterus and the vagina here, and the rectum. So what happens is, obviously we all know that there's a lot of bacteria in the rectum. The bacteria can sort of start forming on the pelvic at the introitus, and then it's very easy for the bacteria to make its way up into the bladder. So one of the things to help prevent it is to, by drinking lots of water, that helps create more urine. You end up peeing more frequently, but you're flushing out the bacteria and preventing it from entering the bladder. And so that's one of the things. There are some really good studies that have shown that people who drink more water are less likely to get urinary tract infections. So that's kind of one of the things that I strongly recommend to my patients that come in and have frequent urinary tract infections. All right. So I know busy slide here, but this is basically to summarize some of the stuff I've already mentioned. So we talked about upper urinary tract infections is when it's involving the kidney. And so the medical term for that is pyelonephritis. And that's, again, you have the flank pain, the fever. Those are the kind of the typical symptoms that people that present with. And a lot of times, if they're really sick, they get admitted to hospital for this condition. If they're stable, then you can manage them with oral antibiotics as an outpatient. They also have fatigue, malaises like fatigue. We look at their urine. They usually have white blood cells. White blood cells is a marker of inflammation. White blood cells by itself, it does not mean you have a urinary tract infection. It's one of the things that's associated. You need to actually see bacteria in the urine for it to be a urinary tract infection. And then they also typically have urinary symptoms, which is like what we see in terms of the bladder infections, which is cystitis is the medical term for bladder infection. And we covered, these are the same symptoms I mentioned earlier: the frequency of urination, urgency, dysuria means painful urination, pelvic pain. Again, you see this white blood cell when we look at the urine test. When you provide the urine sample, we see white blood cells and bacteria. You need to have both in order to have a urinary tract infection. They can sometimes have hematuria, which is blood in the urine. And as I mentioned, it's more common in women. And we talked about most commonly it's E. coli. And then these are the other bacteria we typically see: Proteus, Klebsiella, Enterobacter. Staph is a very common skin bacteria, but sometimes it can go into the bladder and be a cause for urinary tract infections. What are the antibiotics we typically use? Commonly now, we're using macrobid is a very common common antibiotic that we use that works very well for uncomplicated urinary tract infection. So when we say, you may hear doctors say, oh, it's an uncomplicated UTI. What that refers to is usually it's in women. They don't have the fever and chills and all that. They're just the frequency, burning, and they don't have any underlying medical condition like diabetes or immunosuppression that puts them at risk for urinary tract infections. So typically the antibiotics we typically use are macrobid or nitrofurantoin and Bactrim. And then there are some what we get concerned about is these ones, the ESBL. These are bacteria that are resistant to the common types of antibiotics that we use. A lot of times for these kinds of bacteria, we can't give oral antibiotics. You need to give them IV to treat them because they're resistant. And we'll talk a little bit about what antibiotic resistance means in further slides. So what are the risk factors? We kind of talked about some of these. So for elderly patients who are out and about in the community, if you've had a urinary tract infection in the past, that is a risk factor for you developing another one in the future. Postmenopausal women are more likely to develop a urinary tract infection if they've had one before. The thought there is postmenopausal women, a lot of times estrogen is because estrogen levels have gone down. After menopause, there's vaginal dryness. the thought is the bacterial load is probably higher in the pelvic area. And as a result, because of the increased bacterial count, that it sticks to the lining, and because of the vaginal dryness, and it's easier for the bacteria to enter the bladder. That's the thought there. So sometimes we put some women, especially postmenopausal women who have urinary tract infections, we give them topical estrogen cream to apply around the urethra area, and we've seen that studies have shown that can reduce risk of developing recurrent urinary tract infections. We mentioned about the genetic factors. There seems to be like a family, if you have family members with recurrent urinary tract infections, it seems to be does increase your risk. Even though sexual activity I mentioned and urinary tract infection, there seems to be an association, particularly in younger women. We don't see that same relationship in postmenopausal women. And again, we don't know why that's the case. But I do tell my patients who, if they do see an association between sexual activity and urinary tract infections, we talk about urinating right after sexual activity to kind of flush out the bacteria. Sometimes even if they do that, they still get infections. We even give them what's called prophylactic antibiotics, which means after they have sex, they take an antibiotic right at that time before they even develop the symptoms. And studies have shown that can reduce infection from you developing a full-blown infection where you need to be treated for 3 to 7 days. Just by taking one pill following sexual activity, that can reduce your risk of developing an infection. These last two are usually we see in men, urinary retention. So usually when men, as I mentioned, it's less common for men to develop urinary tract infections. When they do develop urinary tract infections, usually it's either a structural or anatomical abnormality, particularly enlargement of the prostate. So the prostate is a gland that men, when they urinate through the prostate. I usually tell people, think of it as a donut with the hole in the donut. You're peeing through the hole of the donut. And then as you get older, that hole of the donut gets smaller because the prostate grows and pinches off. So it's a smaller hole that you have to urinate through. What can happen sometimes then is you don't empty your bladder all the way, and then you have this urine sitting in the bladder, and that bacteria likes urine. So if you're not emptying your bladder, flushing out the bacteria, that stasis, what we call stasis of urine sitting in the bladder, is a good nidus for infection to grow. So then typically we do surgeries on the prostate to help them empty their bladder, and usually that helps treat and prevent further infections. And that's what high post-void residual. What that means is after we usually do in the office, we ask men to urinate, and then we do an ultrasound to see how well they're emptying their bladder. So for patients who are in institutions, so like nursing homes, sometimes after a stroke, or if their functional status is very poor where they can't walk and they need a lot of supportive care. It's sometimes very difficult to make the diagnosis of a UTI, and we'll get into that in a couple slides. And the reason is because usually there's more functional impairments, cognitive, if they have dementia. Sometimes they can't express their symptoms. So if they can't express their symptoms to say that I'm having burning, I'm having pain, it makes it very difficult for us to know whether they're having the symptoms of a UTI. As I mentioned, the presence of urinary catheter is a risk factor. Having a prior urinary tract infection, having a stroke. After a stroke, the communication between the brain and the bladder to coordinate the urination gets affected. So generally speaking, when you have to urinate, it's a very complex, your bladder fills up, but you're not at a place where you can urinate. The bladder sends a signal to the brain to say, hey, this is not a good time to urinate. The brain tells the bladder, okay, hey, find a good spot for me to go, right? So there's all this communication going between the bladder and the brain. And when you have a stroke, that communication is messed up. So a lot of times you have leakage of urine, incontinence, and other issues, sometimes fecal incontinence. And because of that miscommunication, that it can trigger urinary tract infections as a result. Bowel and bladder, so urinary incontinence, the fact that if you're leaking and underwear is wet or pad is wet, or fecal incontinence, so you can't control your bowel movements, you're obviously just increasing the bacterial load in that area, and that can increase your risk for infections. So incidence, very common. About a third so UTI accounts for over a third of all nursing home associated infections. It is second only to pneumonia in patients who are in nursing homes. So it's the second most common type of infection. Mentioned already that it's higher in women compared to men, and that's across all age groups. Over 10% of women older than the age of 65 have reported having a UTI within the past year. That number increases up to 30% over the age of 85. And again, we'll talk about the fact that it's hard, it's very challenging in the elderly population because some of the, trying to figure out the criteria for diagnosing a UTI can be a bit challenging. Again, this is just a diagram showing that for infants, urinary tract infections are kind of common when at less than 1 year of age, and sometimes it can be because they have some anatomical abnormalities they're born with where the kidney doesn't drain very well, so that puts them up for infections. Or sometimes I said in boys who are uncircumcised, they can get infections within the first year. And then as you get older, for men it stays pretty flat until they reach kind of around 50 to 60, and then they start developing prostate problems. Then their incidence of infections goes up. For women, it's again in the younger age, it's sexual activity in the 20s to 30 age range is pretty common. And then as they get older, and then the postmenopausal age range, we see another spike in the infection risk or infection incidence. Okay, so that's urinary tract infections kind of in a nutshell, the base kind of things I wanted to cover. The next, what's very important and kind of what I wanted to spend a lot of time on was to distinguish what a UTI is, which we've covered, versus what's asymptomatic bacteria. And so there's a big difference between the two. And doctors get this wrong all the time. Okay, so it's the key thing is it's a laboratory diagnosis. And generally what happens is we just look at the urine and there's bacteria in the urine. But even if you have bacteria in the urine, it's not a UTI because they have no symptoms. So that's the difference between a UTI and asymptomatic bacteria. So UTI, you have bacteria in the urine and you have symptoms: frequency, urgency, pain, blood in the urine, all the things that we talked about already. Asymptomatic bacteria, you just have bacteria in the urine, but the patient has no symptoms. You do not need to treat those patients except for a couple incidences which we'll cover. But generally, UTI, you treat. Asymptomatic bacteria, you do not treat. Another term I wanted to, pyuria, is a medical term. It means, pyuria means pus in the urine, so infection. So all that means is that when they look on the microscope, they see what's called WBCs, white blood cells. White blood cells is just a marker of infection. So a lot of times, you go to the doctor, you think you have a UTI, they take a urine sample, they tell you right away, oh yeah, you have a UTI. Actually, they can't tell you right on the spot that you have a UTI. To tell someone they have a urinary tract infection, you have to wait at least 3 days to get the urine test back. But most of the time, they just give you antibiotics because it's like, oh, they see white blood cells and they know they say you have a UTI. The urine should be sent to the lab. It needs to be checked for bacteria. Okay? This by itself is not enough to say that you have an infection. And again, this white blood cells is very common in what's called asymptomatic bacteria. In elderly patients, some studies have shown 90% of elderly patients have bacteria in their urine. And again, if it's not bothering you, you do not need to be treated. Okay? People who have catheters, short-term, less than 30 days, if you've had a catheter in, it could be 30 to 75%. Long-term catheters, where you've had it for like a month, over a month, get up to 100%. And you have a foreign body that's sitting in the bladder. There's going to be bacteria on the catheter. That bacteria is going to enter the bladder. But if you're not having symptoms, you do not need to be treated just because you have bacteria in the urine. So just to summarize again, definition: so UTI, infection anywhere in the urinary tract, whether it's upper or lower. Symptomatic UTI, that's where you have LUTS means lower urinary tract symptoms. So you have symptoms with bacteria in the urine. Those are the ones we treat, okay, with antibiotics. Asymptomatic bacteria, you have bacteria, but there's no signs or symptoms. You do not treat this. Asymptomatic pyuria, you got white cells in the urine, but no symptoms. You do not treat this. The only one we treat is the symptomatic UTI. And again, just to harp on the fact that it's very common, this asymptomatic bacteria, it's definitely more common as you get older. So we see it more in the elderly population. You can see the numbers here, 1 to 5% in young women. You get to age 65, up to 16%, about 20% over age 80. But patients who are in long-term care facilities, it can be up to 50%. So So like if you go to the doctor's office and sometimes they take a urine sample and you're not having any symptoms, really they don't really need to check a urine sample if you're not having symptoms, because if there's bacteria, you're not going to want to treat it, because unless you're having urinary symptoms. Men is less common, as I mentioned, it is less common in men than women, so you can see the numbers here about the same kind of increases again with age. Here we're doing okay. This is kind of very similar, same numbers from a different study showing the same thing. It does increase as your age goes up. I think we've covered this. So the only thing I'll point out here is, again, the typical symptoms are what I mentioned: urgency, frequency, burning with urination. Some patients can have the non-specific symptoms, which I think I've covered. The difference between for women and men with asymptomatic bacteria is that for women, you need to have 2 urine samples that show the same bacteria to have this condition, to be diagnosed with asymptomatic bacteria. For men, as long as you only have 1 urine sample and it shows bacteria, then you're considered having asymptomatic bacteria. Now, the big thing is, so hopefully I made it clear the difference between a urinary tract infection and this asymptomatic bacteria. The problem where we get as physicians is the patients who are in institutions who have dementia, who cannot communicate, because as I said, to distinguish UTI from asymptomatic bacteria, you need to have symptoms. If a patient cannot communicate, if they're nonverbal, if they cannot communicate the symptoms, then how do you know whether they actually are having a UTI versus not, if they cannot communicate? That's where the dilemma gets, and that can be the difficulty for a lot of us to determine whether to treat or not. Because they can have sometimes the atypical symptoms where they're not eating as well, they can be confused, their general functional status declines, or their only symptom can be fever. Just a note about how we collect urine samples. For men, we usually just collect a midstream urine, or if they cannot provide it, if they're functionally not doing well, we can put a condom catheter on and collect a sample that way. Women, again, if they're able to provide a midstream urine, that's what we collect to see if they have an infection. Otherwise, we can do what's called an in and out catheterization, where we put a catheter in the bladder to get a urine specimen directly from the bladder to see if they have any bacteria. If someone has a catheter permanently because they cannot pee on their own, what we do sometimes is if it's been over 2 weeks, we change the catheter, and when we put the new catheter in, there's always a little bit of urine that comes out, so we grab that urine and send that off to see if there's any bacteria. So this is what's done in the doctor's office, which is not the most reliable, and a lot of times, you come in, you give a urine sample, they just use a little piece of paper, put it in, they look at it, they compare the colors to the scheme, and they tell you, oh yeah, you have a UTI. And what they're looking at is what's called leukocyte esterase, which is an enzyme that's found in white blood cells. So again, the fact that they're just telling you have a UTI because there's white blood cells, but that, as I mentioned, is not the only criteria to determine if you have a UTI. And they also look at what's called nitrites, but only certain bacteria show nitrites. So this is not the most reliable test. The most reliable thing is sending it to the lab and seeing if any bacteria grow over like a 72-hour period. So this slide, all I want to mention is that it's very important to do the urine culture, like I said, in order to be diagnosed with a UTI. That's changed actually. 10 years ago, when I was still in training, we used to say if someone just came in, especially a female, had the symptoms of a UTI, they were just like, don't even bother, you can just treat them for 3 days of antibiotics. And that's totally changed now. The guidelines have totally changed, where before you treat a UTI, you should get a urine sample so you know what you're treating and to document that you actually have a true infection. All right. And the other thing that we've gone away from too is a lot of times we used to treat for a UTI. If someone had a UTI, like symptoms and bacteria, we put them on antibiotics. We used to also do a urine to recheck the urine after they were done. And now they say that's now no longer necessary. As long as your symptoms are gone away and you're not having any more problems, you do not need to check another urine sample. Okay. And then we do blood cultures, which is if we're concerned about an infection that's gone from the urinary tract into the bloodstream. That's when you can develop, like I mentioned, sepsis, usually with fever, chills, and your blood pressure goes down. It can be life-threatening. So we check using these vials to see if there's any bacteria in your blood. All right. So for asymptomatic bacteria, when should as I said earlier, and I've kind of harped on this many times, is we do not treat it when you have bacteria but no symptoms, except these two cases, okay? Pregnant women. If you're during pregnancy, they check very commonly when you go for your routine checkups with your gynecologist, they always check a urine sample. The reason being because if you do have bacteria, even if you don't have any symptoms, it's recommended to treat it, because as you get further along in the pregnancy, having a UTI can cause you to go into preterm labor. And there's also some concern about maybe some certain bacteria, particularly what's called group B strep, can be transferred to the fetus and can cause some neurological issues. So pregnant women is one of the reasons we do treat if there's bacteria in the urine, even if they do not have any symptoms of a urinary tract infection. And the only other reason we treat is if someone is going for a urology surgery. So TURP is like a prostate surgery or kidney stone surgery, any sort of intervention where you're going to be putting instruments in the urinary tract, you should treat with antibiotics before doing the surgery. Those are the only two times for asymptomatic bacteria. And again, for all the other cases, we do not treat. So again, premenopausal women, non-pregnant women, they don't need it. If diabetic women don't need it if they're not having symptoms. Elderly people in the community or in long-term care facilities, they don't need it. Patients with spinal cord injuries or catheterized patients. So these patients should not be treated if they don't have symptoms. And studies have shown that there's no benefit. And those are both large long-term studies as well as randomized studies comparing patients with asymptomatic bacteria who underwent treatment with antibiotics versus no treatment. They showed no benefit, no decreased rate of symptoms, and no improved survival. And these are just the studies that are there. So the Infectious Diseases Society of America recommends not doing screening or treatment for this condition, even in the elderly population. But at the same time, some people are like, well, why not just treat? Like, isn't it just easy? It's an antibiotic, it's a pill, just take it. What's the downside to it? And I think next few slides, I'll show you the main issues with treating with antibiotics. Antibiotics are good when you have an infection. If you do not have an infection, these are the problems that can occur. You can develop side effects. All medications have side effects, and some of them can be pretty significant. We used to treat a lot of urinary tract infections with ciprofloxacin. It's a very common antibiotic, and now studies have shown that it can cause like ligament damage, ligament tears, and other side effects. And Bactrim is another common antibiotic we use. Some people have strong allergic reactions to sulfa and can get fixed drug reactions as a result from it. So this is not something to take lightly. And that's why you can't buy antibiotics over the counters, because there are significant side effects associated with it. You can develop multi-drug resistant organisms. So the bacteria can change. So you had a UTI, you've gotten multiple antibiotics. What can happen over time is the bacteria that you have they're smart. They change and they become resistant to the antibiotics that you're used to getting, and then it becomes harder to treat the urinary tract infections down the road. And then the worst thing you can get is C. diff infection, which is a serious GI condition and can be life-threatening. Studies have shown that antibiotics are misused in hospitals. It's been recognized for several decades that up to 50% of antimicrobial or antibiotic use is inappropriate. That's pretty significant. It means 1 out of every 2 times someone is prescribed antibiotics, it's inappropriate. They should not be getting it. This is from the IDSA, which is the Infectious Diseases Society of America. In 2008, there were 142,000 visits to the emergency department for adverse events attributed to antibiotics. So you thought someone gave you an antibiotic for an infection and you developed a side effect. 142,000 visits to the ER in just 1 year. The urinary tract infections, just another statistic, but in the United States alone per year, about $2 billion are spent on urinary tract infections, investigations, evaluation, treatment. If you factor all that in, $2 billion, that's in the United States alone. This is kind of showing what happens with the antibiotic resistance. So Here's you've got the blue bacteria is the one that's sensitive to the antibiotics. The red one is the one that's resistant. What happens is you go to the doctor, they prescribe antibiotics, you get rid of all the blue stuff, but then the red one that's resistant, it gets stronger and then it multiplies, and now you've got this resistant bacteria, and then now you're stuck with a bacteria that's very difficult to treat, and they can actually transfer their drug resistance to other bacteria. So you're just compounding the problem by taking antibiotics unnecessarily. So antibiotic resistance travels. A lot of times patients, I'm sure you've seen patients in the hospital, they have MRSA, VRE, these are all resistant bacteria. They have to be placed in isolation. You see that all the healthcare workers are going in, they have to gown up and glove because you don't want to transfer they've got bacteria on their skin that's resistant and difficult to treat. Now you're going from room to room, you're transferring that bacteria to the other patients, then those patients are going to long-term care facilities, that bacteria is being spread over there. It's kind of like similar to what daycare for kids, right? Except it's daycare for adults where you're transferring all these infections. It's no different. C. diff is, I'll spend a couple slides on this. It's probably the single most risk factor for antibiotic exposure is the single most important risk factor for developing C. diff. What happens again is you get rid of all the good bacteria and then this bad bacteria proliferates and usually presents with severe diarrhea, very watery. You develop these spores show up in the GI tract. And we've kind of seen, because antibiotics are so commonly used, what's happened now is we're seeing the incidence of C. diff is continuing to increase as the years have gone along. We're using more and more antibiotics, so C. diff rates are going up. And this is kind of what it looks like. Inside it should be nice and smooth, but you've got all these like cobblestoning, and we call this pseudomembranes involving the colon, and it can be a life-threatening condition. Everyone's worried about coronavirus, but we should be, I think, worried more about C. diff and norovirus here. All right. What are the risk factors for it is mainly antimicrobial exposure, advanced age, if you're immunocompromised, underlying illnesses like diabetes, hypertension, tube feeds, and if gastric acid suppression. So if you're on proton pump inhibitors, sometimes that can be an exacerbating factor. Okay. So I think I'm getting close to the end here. I think we've harped on this quite a bit. Again, some more stats. Antibiotics most commonly prescribed medication in long-term care facilities. Up to 70% of long-term care facilities residents receive an antibiotic every year. And you can see that as far as the cost of antibiotics are continue to go up. And again, like I said, long-term care residents, it's very common for them to be colonized with bacteria, and it's very easy for it to transfer from one resident to the other. I'll wrap up by just saying a couple things. So things to help us to determine whether to treat UTIs or not. They've actually come up with criteria. We've got two of them mainly that are mostly used, what's called McGeer criteria and Loeb criteria. It's they've kind of given us guidelines to help physicians determine whether someone in a nursing home should be treated or not. We have an algorithm, and here are some of the guidelines. I'm not going to get into it. I think it's too much to get into. But they're basically, they suggest symptoms that, clinical factors that we look at, as well as lab factors in the urine test to determine whether we should treat or not. So I think last thing is, again, the toughest thing is when patients who have underlying neurological conditions, particularly delirium. It's not just because if someone's cognitive status changes, they become more confused, because sometimes that can be the only symptom of a UTI. But just because they have confusion doesn't mean that that they have a urinary tract infection. Other things can do it. Like certain drugs can affect cognition. There's something called the Beer's criteria, which is a list of all drugs that should be avoided in elderly people because they have the significant side effects. Oxygen states, having heart attack, stroke, obviously these things can affect your cognition. Infection, not necessarily UTI, but can be pneumonia, another site of infection, urinary retention, dehydration, and then metabolic causes if you're diabetic and low blood sugar, can present with confusion. So just because someone's in a nursing home and confused, and it's very common that they check, a lot of times they're like, oh, it's a UTI. It's very easy to blame it on the urine. This is Beer's criteria. So if you look up, there's for doctors to look up to know which medications to avoid in the elderly population. So I usually talk to them about that. And then we have these protocols. Like I said, a lot of nursing homes have this where they have this to help guide them whether a patient should be treated with antibiotics or not. And finally, just how things to do. I usually tell this to patients on avoiding UTI. We've talked about this already. Urinate before and after sex. Drink lots of water. Proper genital hygiene when after using the restroom, you're wiping from front to back. Try to avoid irritating feminine products, and sometimes some spermicides and diaphragms for contraception can actually increase your risk for UTIs. And I think that's pretty much it. I think.
Okay, Dr. Dar, thank you so much.
All right. Thank you.